then immediately weekly, and then for 2 weeks, and then you can have it on alternative weeks. If one of the fetuses die, it means that we have too much occlusion of the vessels. We have to consider that the other co-twin may suffer from damage, and the neurodevelopmental assessment should be done at late pregnancy as well as after delivery for 2 years of age. There is another type of abnormality which is also related to monochorionic diamniotic, almost similar to the TTS in the sequence of events. However, it is anemia polythalassemia sequence. It's called TAPS. It is 5% spontaneously, may complicate 13% of the TTS treated by laser. It is very simple. It is the arteriovenous anastomosis, which are very small, allowing slow transfusion of one of the baby, which is the donor, to the recipient, leading to high discordant hemoglobin concentration. I mean, one of them will suffer from severe anemia, the other will suffer from polythalassemia. How can we diagnose anemia and polythalassemia intrauterine? Everybody knows that we can rely on the middle cerebral artery, peak systolic velocity, MOM, which is the MOM, more than 1.5 or less than 0.5. More than 1.5, the multiple of the median, we are speaking about anemia, and less than 0.1, we are speaking about polythalassemia. So, polythalassemia, less than 1, more than 1.5, it is anemia. So we can rely on the middle cerebral artery in diagnosis. This is how can we also stage them. Again, we are having difference in hemoglobin concentration, but the most important is to diagnose. How can we diagnose them? That's why we are using the middle cerebral artery peak systolic velocity. In any case, in monochorionic, diamniotic, with complications, we have to do the peak systolic velocity of the middle cerebral in order to exclude this tap. What are we going to do? Actually, the management is very difficult because, as I told you, it is having a high risk of being a death of one of the fetuses. They are now considering intrauterine transfusion, exchange transfusion, but most of the cases which are not reaching very higher stages, I mean, there is a mild anemia, there is a mild polythalassemia, the conservative treatment will manage, and early delivery is accepted. And in this case, most probably the patients will going to suffer in a mild situation. The last thing is the TRAP sequence, which is called acardiac twinning. It's a very rare abnormality, but we have seen it many times. It's called twin reversed arterial perfusion, TRAP, or in the past we call it acardiac twinning or cardiac monster. It is characterized by having an artery-to-artery anastomosis, and the developing fetus is not having a heart. So we have a fetus with a normal heart, and the other one is not completely developed, have no heart, and the blood is coming from the healthy to the other one, and it is pulsating by the heart of the other one. So that's put a great load on the healthy fetus, and if this parasite or co-twin is large enough, it will lead to heart failure in the existing one. So this is what we call the parasite or the acardiac twinning or the TRAP. As you see here, we don't identify except the lower part of the body. We expect we don't have any heart. The pulsations are coming from the existing twin. And that's why this is many types of the twin pregnancy with monochorionic diamniotic, which are complicated by having acardiac twinning. This is the picture, some of the pictures after that. This I have being faced with this type of pregnancy. As you have seen, this is triplet, and this is one which is dichorionic. This is one chorion, one amnion separately, and these are monochorionic diamniotic, and one of them is monster, I mean TRAP sequence, and this was in zooming, And this pregnancy continued up to 20 weeks, but later on had severe preterm labor. The acardiac twin is thus a parasite. So it is parasiting, it is depending on the ecosystem of the other. And this is important. Overall, 50% of the pump twins survived. So this is a high percentage. So we have to follow up the Doppler of the twin, of the healthy twin, and to see that the heart is still pumping in a good way. The other way is to get rid of this one by selective feticide, by doing it by fetoscopy. Doing a ligation of the cord is the only way to get rid of this one and deliver the baby at a certain level of time in order to prevent again the new developmental abnormalities that could appear. Monochorionic, monoamniotic. This is a very clear type and very dangerous type of monochorionic. Only 5% of the monochorionic are there. You don't find any intervening membrane between them. So be careful to diagnose monochorionic monoamniotic. It is extremely important because entanglement of the cord is present in every case. The cord is entangled in every case. And it has a very high possibility of prenatal morbidity and mortality. And I'm now just saying again this slide because it's very important. What about the surviving twin after the demise of the co-twin? What are the possible complications that happens comparing the monochorionic with dichorionic? And what about the surviving twin? This is a very important slide. Again, we could have death of the co-twin, preterm delivery, postnatal neurodevelopmental abnormalities in the surviving, and cranial abnormalities during the third twin. Before I finish this one, it is in monochorionic, I'm just saying very clearly, it is recommended now that the monochorionic monoamniotic pregnancy is delivered by the time of 32 to 34 weeks. This is guidelines of the British, and it is recommended that once you have a monochorionic monoamniotic, you have a very high risk of sudden death, very risk of cord entanglement. So single fetal death is very common, and you will carry the risk when one of them is dead, dead. You will have all the complications that happens. So it is almost, I have a